Dear colleague, welcome to this session on left main and complex PCI in patients with high bleeding risk. It's a session supported by Thierry. And during this session, we will see a nice live case from Maciej performed by Thierry Lefèvre and Philippe Garot. And just about the learning objective we'd like to achieve together during this session, the first is to appreciate the value of transradial approach for left main and complex bifurcation PCI, but also to acknowledge the Ultimaster DES results in bifurcation and high bleeding risk patients, and to understand how to optimize the strategy and the technique using intra-coronary imaging, and namely, in this case, OFDI. So for that, I'm very happy to chair this session with Gabor, Toth. We have as discussant Francesco, Burzotta, and Maciej Lesiak. And for the live operator in Maciej, we will have Thierry Lefèvre, Philippe Garot, and Onuma. And to help us, we have the chat master, Hakim Benamer, who will collect your question. And speaking about question, maybe you want to mention something specific, Gabor?
Yeah, I think what is important there, we will discuss here patient HBR, complex coronary heart disease. This is the type of patients what we all see in our everyday practices. So please use this opportunity. There are microphones in the audience, and you can also have the chat application to make your questions in order we can really discuss this case together.
Yeah. So maybe, Gabor, we can start by presenting the case, and I'm sure that's the type of challenging case you experience many times in your daily practice.
So we will discuss today, together with you and the team in Maciej, a patient with left main bifurcation lesion, high bleeding risk. So the patient is 90 years old, but the biological age is definitely lower. He is really an active lifestyle patient. Here you can see the risk factors. In the previous history, it's very important to mention he had already twice TIAs and is presented with severe angina. And the echo showed good ventricular function with no valvular disease. In the laboratory result, what is important to emphasize is the impaired renal function. His regular medication contains aspirin, and on the ECG is incomplete bundle branch block. And now we right away focus on the angiogram, the diagnostic angiogram. And you can already appreciate that there is disease involving the proximal LAD and the proximal circumflex. In the LAD, actually, this is a relative extensive disease reaching the level of the first diagonal. Here you can see that this is a large left main, large circumflex, and actually the lesion in the LAD ostium and the proximal circumflex is really critical. And in the right coronary artery, we see that there is a long lesion. I would call it intermediate, might be significant, difficult to say right here, right away. But I let you digest this angiogram first. You see from the other projection. So I think on this slide we can summarize everything. What is the most struggling question for this patient? Complex left main disease, and there is no need to explain why the patient is at high bleeding risk. He is old. He has impaired renal function. So I think met the criteria for our session today.
Yeah, clearly, Gabor. So we have a, let's say, very old patient, clearly a high bleeding risk patient, and with significant multivessel disease because he has a tight distal left main involving also the proximal LAD and the right, which can be considered, depending to your eyes, probably intermediate or significant. So I will start asking Maciej, maybe, regarding the multivessel strategy in this very frail and HBR patient. What will be your strategy?
Yeah, thank you. Of course, the main reason to completely revascularize patient is not only to relieve their symptoms, but also to prolong life. But once you obtain, once you live long, I think the strategy should be different here, yeah, because now we see triple vessel disease, but I have some concern about the right coronary artery, whether it's significant or not. And of course, the most significant lesion, definitely a hemodynamically significant lesion, is proximal LAD. So I will concentrate on this lesion. Of course, this is ostial stenosis, so it cannot be done without touching left main. And I want to stress how important imaging will be in this situation, just to understand the anatomy and to decide which technique should be used. And to me, the most simple technique, the better, the simpler technique, the better for this patient, because as I mentioned in the beginning, for this patient, 90 years old, fragile patient, the main issue is to release the symptom and to just to fix the most important significant lesion in her heart. Yeah.
Okay, so because of the patient and the HBR, you will focus on the most critical. Francesco, do you have any other?
I think that these the comments were very well placed, because we know that there are emerging data in different clinical scenarios, stable, unstable, cardiogenic shock patients, showing that complete revascularization at the end may impact long-term follow-ups. But I mean, curves need time to diverge. So this means that you should adjust your procedure according to the individual patient you are treating. And 90 years old so far is still something more than the expected lifespan for a patient, people that lives in our countries in this world. So it is difficult, I mean, to impact strongly in the long term. Here we see a significant lesion that may impact the early outcome, and so it makes sense. I don't know if in this particular case, but we use in our cath lab many times in these conditions the FFR in order not to overtreat these lesions. Here I see that in both vessels, the circumflex in terms of ostium and the right coronary artery, a huge artery in terms probably aneurysmatic, so it is even difficult to understand which is tight stenosis over there. So it is another approach to reduce stenting.
Okay, thank you, Francesco. Maybe I see that Thierry and Philippe are already in Maciej, but a very short answer. We have a T-shape left main, significant disease on the LAD and the circ. It's quite calcified, but on the opposite, we still have HBR patient. So what will be your strategy before going to Maciej and see what they
provisional. I will start with left main LAD, crossover stenting, and then see what happens.
Okay, Francesco, same.
Agree. One more advice. We named imaging, but when you have this suboccluded LAD, it makes sense to firstly predilate before assessing. So it is also another important point in my mind.
And Gabor,
limit ischemia.
Regarding the high bleeding risk of the patient, do you think it can have any impact on the PCI strategy for such complex left main?
Well, I would phrase it as the others just mentioned. We have to balance the ischemic and the bleeding risk at the end. Patient old with severe angina, so the goal is to make him angina-free, I would say. So I think we have to minimize our strategy for the really critical problems, but there we have to achieve really optimal result with good opposition, good stent expansion. So I agree that minimalistic strategy, probably image guidance would be really relevant here.
Yeah, so I think we can, with all this discussion, I think we can now go to Maciej and we realize that you really select a nice and challenging case, both for the patient and anatomy. So Thierry, Philippe, all the team, it's yours.
Okay, welcome to Maciej. It's really a pleasure. It's really a pleasure to start this session on HBR patient. We heard your discussion, which I think was very interesting. And the first thing that we have to say is that we have done FFR during the coronary angiogram. And surprisingly, the FFR was 0.87. So we have already solved one of the problems, which was a multivessel disease. So we just have now to treat the problem of left main 0-1-1 bifurcation lesion. So can we move to the slide? So this is our conflict of interest. Next one. So it was decided to do PCI with a stepwise provisional approach, looking at the coronary angiogram. You will see that now we have done some images which are very interesting. Next. What we are going to focus on is how to manage an HBR patient with left main disease, and also how to treat Medina 011 left main bifurcation lesion. Next. So we start with a transradial approach. We decide to use 7 French in order to be comfortable with kissing balloon, if we use 2 stents, etc. The plan is to pre-dilate with a non-compliant balloon the LAD, stent from left main to the LAD, do a pot, then a kiss or just open the side branch and decide if we have to treat the circ with a stent as a T-shape or tap configuration. At the end, we plan to use OFDI just to be sure that the stent is fully apposed in this patient, which is HBR patient, in order to be able to stop early the DAPT. Next one. Okay, so thank you very much. So Philippe will show you the 3 images that we have done. So we are in 7 French. We put the wire in the circ very easily. Philippe?
Yeah, so hello everybody. This is the first injection that we did in the left system, and you can see there is a tight left main lesion, typically 011, involving ostium of LAD and ostium of circumflex, which is a big branch. And you see in this RAO caudal view, there is a kind of spider view. We don't see clearly the origin of the LAD, but we can see that the lesion of the circumflex is really tight on this view. It's a big vessel as well. And finally, this is a LAO cranial view where you can see the ostial LAD, which is tight, and a lot of calcium in the left main system and the proximal and middle AD. So as Thierry said, we just start now the procedure. We just before live just put a EBU 7 French and a wire in the marginal, and we are ready to start the case with you today.
Okay, so while Philippe is wiring the LAD, I thought it will be interesting to show how to manage that. We can discuss about the strategy. Looking at the angiogram with a good angio, we have the feeling that at the end we'll put the 2 stents in this case, because the circ is dominant, or at least important branch, and the lesion is really tight. So I don't know what is your opinion about that.
Thierry, you said it's a high probability to put 2 stents, but still you want to start provisional to let the door open for 1 single stent in this HBR patient, correct?
Yeah, absolutely. But of course, we anticipate that the need for a second stent will be high in this particular patient.
And
so the strategy is unchanged. So we will pre-dilate the LAD, stent from left main to LAD, then do proximal optimization technique, and then we'll discuss what we'll do.
And Thierry, regarding the size of both LAD and circ branches and the angle, do you already have in mind, I'm sure you have, the 2 stent strategy that you will use if the provisional is not enough?
Yeah, of course. Of course. So the plan is to do a T stenting or a tap if we are not able to see clearly the separation between LAD and circ. And we have done many views, and you have seen that we have not an optimal view to see this separation between LAD and circ. So maybe it will be a tap. We'll see. As we like to say, the best tap is a T. But sometimes you are not able to do a T.
So we have crossed the lesion, the LAD lesion, quite easily with a run-through wire. I think you have seen that. And now we are going with a non-compliant 275 AcuForce balloon to treat the distal left main and the proximal LAD.
Ultimaster, Philippe.
It's a balloon, non-compliant balloon.
Yeah. Yeah. From Thermo.
Okay, predilation. Okay, so we go to 12.
I think you can go to high pressure just to test that you are really
Thierry, we have
able to open. Yes.
While the balloon is inflated, Maciej would like to ask a question.
So it looks good, huh? The opening of the lesion is good.
Yes.
But the lesion is longer, so maybe we can...
So there were no issue with delivering the balloon into the lesion, which is a good sign, which is a really good sign.
Absolutely.
You chose NC
and you have
balloon.
seen that... Yeah.
Absolutely. And you see there is a second lesion on the at the level of the septal branch, and I think we are going to predilate this as well.
Yeah.
Just to be sure, you see in this cranial view that we will have no...
Because we see a lot of calcium on the angiography, so perhaps this is a deep calcium that will not, influence, especially.
Yeah, absolutely.
And Thierry, did you have in mind dedicated device in case the non-compliant balloon might not be enough in this case?
Yeah. So the plan is to do a provisional shockwave technique if we're able to put a non-compliant balloon.
So there is.
See, the second lesion is well open too, so it's very good news.
So what's the pressure in the balloon?
Only. 12.
Okay.
So relatively low pressure. So maybe, Philippe, we can use the balloon to measure the length of the stent that we need to...
Yes.
Thierry, we had a question from Gabor.
All the lesions.
Yeah. Gabor speaking. The patient has impaired renal function. Do you have any consideration during the procedure how to spare contrast, or you just go on like in normal cases?
No, it's a very good question. All patient creatinine clearance is 46. So our goal is to use less than 150 cc of contrast. So 4 times the value of creatinine clearance. And so we'll, of course, limit the injection of contrast, but we want also at the same time to have optimal quality of the angiogram to be sure.
Yeah.
So the plan is to do FDI at the end, but we'll do only one run. So one run is about 15 to 20 cc of contrast, so it's not a lot.
And Thierry, here for the audience, you decide a 1-to-1 ratio for the size of the balloon to be sure that the lesion will be well opened and well prepared. Yeah.
So we estimate that the size of the LAD is about 3.0, but just to avoid dissection, we use a 2.75 because we anticipate that we will go to very high pressure, which was not the case. So it was a good surprise.
Yeah.
So Philippe, do you think?
So we have done an injection with the balloon inside the lesion covering the distal left main. I think it's okay for the proximal part, the proximal marker of the balloon in the left main, as you can see there. And this balloon is a 15 millimeter long balloon. So if we want to go to the septal branch, which is the plan, I would use 28 or millimeter long stent, if you agree.
So we were hesitating between 28 and 33. I think, 28 will be okay.
It's true that the distal landing zone, it's...
Yeah. But that's not a big compromise. If you use 33, you will land a little bit further, and then...
Yeah. Okay. So we'll use the 33 just to be sure that we will not need to add a second stent.
Yeah.
Okay.
Thierry, also maybe one comment we had, it's how much you will put in the left main in order to be able to do a proper pot when you decide the length of the stent left main LAD.
So the minimal balloon length that we have is 8. So we need at least 8. But in this case, I think with the 33, we'll have probably a little bit more than 8 millimeter in the left main. And you have seen that there is some distal lesion in the left main, but not too much. So if we have a scaffolding of 10 millimeter in the left main, I think it will be okay.
I think it's
So we have
important what you just
selected-
mentioned, because in case you might end with a TN protrusion, you have to come back a bit with the pod balloon as compared to carina. So when you are planning your first stent, you already incorporate this idea that the final pod after tap is even more proximal.
Yeah, absolutely. Yeah, I think it's a very important point if we do a tap, because we should avoid touching the distal part of the left main if we do tap, in order not to destroy the tap technique. That's why I'm saying that the best tap is a T, because if you have a T, you can go up to the bifurcation. So you can see that the stent is going relatively easily.
So what's the diameter of a stent? So this is Ultimaster 3 or
very
3,
important
3.5.
point. Yeah. So we select a 3.5 because we want to be sure that the stent, the scaffolding of the stent will be optimal. If you use a 3.0, of course, it's the size of the LED, so go to 7 only. It's very important to use a 3.5 for left main, because remember that the 3.0 is a 225, it's the same stent. So the scaffolding will not be optimal. So we go to low pressure, not to damage. It takes time. So we are at low pressure, 7 atmosphere. You can go to 8. And at the end, we'll do kissing balloon inflation. So
is patient tolerating this well? Yeah. Oh, now we see the pressure. Yeah. Thank you.
Yeah, you see the pressure. Est-ce qu'on peut mettre du jaune et pas du rouge, parce que le rouge sur noir, ça marche pas. Okay, so do we want to go to maybe to a little bit higher pressure, Philippe?
Or to change the balloon?
Oh, yeah, right. Yeah.
And do you use, Thierry, some stent
Maybe
enhancement, like stent boost or stent vis in the...
Yeah, so we can do a stent boost live.
Yes. Definitely you will have to do a dot, distal optimization, because the most of the lesion was concentrated in this proximal LID.
Yes. Of course. But we can do the dot when we do the kiss. So,
sure.
So we don't need to do it now. Of course. It's not necessary. Okay, je crois qu'on est... Okay. So you can see the stent boost live with a poor optimization of the stent at the level of the distal left main and at the level of the distal lesion
of the second lesion,
in the proximal LED. Okay. So next step is to do the pots. So we select 4.5.
And Thierry, what you said is you select a 3.5 to keep the capacity of overexpansion of the stent in the left main up to 4.5. I think that's really important teaching point.
Yes.
I fully agree. So, and this is true for all kind of stents.
But many stents have more than 2 designs. With Ultimaster, it's easy because there is only a small one, which is up to 2.5, 3.0, and then 3.5 and 4.0 is a big one.
Yeah.
And it can go more than 5. So expansion limit is really great here.
Yeah, I think it's a very important point, especially for left main, that sometimes you have to take this compromise to choose the larger stent design, which might be a bit oversized for the distal main branch, in order to be sure that you can achieve good opposition in the left main.
That's exactly why. And also to check the material you have in the cath lab to be sure you have 4.5, 5.0 balloon, because sometimes you realize that you used the last one.
And also, a very important thing, perhaps we should stress it again, that you don't need to cover the whole left main, especially if you do some imaging and there is no much disease there, but be sure to leave a landing zone for your pod balloon. So check first what kind of, how short your pod balloon is, because sometimes you leave like 2-3 millimeters of a stent in the left main, and then it's impossible to do the proper pod with 8 millimeters balloon, and very often you have like 12 millimeters balloon, and you may just damage the left main. So this landing zone is very important here.
Yeah, please, Philippe, go ahead.
No, we are waiting for the balloon for the pot.
No, so but it's nice, Thierry. We had some question from the audience also about the use of imaging in this case, which might have been useful for the assessment of calcification, and maybe with imaging, we know OFDI is great to assess calcium, but some people suggest IVUS as a pre-PCI run, and to decide to use a dedicated device or not. Thierry,
Thierry, the question was about imaging prior to stenting, yeah, which of course helps, but this we have 90-year-old lady, yeah, so we have to keep in mind this. Yeah.
It's a male patient, but it's the same. So we could have done a pre-angioplasty
imaging,
yeah.
But the patient renal function is poor. So that's why we decide to use imaging only at the end. I think it's
it really makes sense.
We can do that. Yeah.
So, Thierry, in the meantime, I want to emphasize two aspects during this particular stage. You are waiting for the POT balloon. Someone may tell you, okay, in the meantime, just post-dilate the distal LAD, the proximal LAD distal lesion, because the stent is under-expanded. But I think that it is very important, the fact that we respect the flow of the best procedures. That means we have here huge malapposition inside the proximal main vessel, and and even to advance a balloon may create a distortion over there. So it makes sense to formally perform a POT and then take advantage of the full apposition and going on. First aspect. Second aspect.
Absolutely.
In this particular condition, I do not know if you already did, probably, but before performing a POT, I like very much the idea of having an angio check just to see if there is flow inside the circumflex. Why? Because we know that there was lesion. If you induced some carina shift, it is possible to restore the flow immediately. So, and if you apply POT, it will be much more difficult to enter the circumflex. So, just immediately before performing the POT, just a small scout allows you to be sure that there is no problem in the circumflex. So this is exactly what Philippe did.
And this also goes well with doing a dot distal optimization after rewiring, because we may push the carina towards the side branch and lose this large vessel.
Thierry, interestingly, it was difficult to cross the distal left main when there is some stent under expansion with the...
No, I think it will not be an issue. Unfortunately, the 8mm balloon disappeared. So I don't know why.
Have a 12.
So we use a 12, but we have enough space with a 12 proximal to the distal left main. So just check that the wire is really the good wire.
Okay, it was on the
LED.
It was on the circ.
It was on the circ.
And really important is to take care before the pot, as you said, not to hurt the stent with anything, and especially with the guide. You see that we have to take care that the guide wire is not going too deep. Maybe test.
And another issue is that as long as the circumflex wire is jailed, the guiding catheter will never point into the lumen of the left main. It will always point it at the edge of the stent, So you have to do it very carefully. Be very careful with advancing any large size device.
Yes, especially big non-compliant balloons.
And small tips, Thierry, do you use sometimes different color of wire to check which is the circ and the LED?
No.
You just do?
Usually the wire is positioned on the table like they are in areocaudal view. So the circ is, if you can show on the table, circ is close to Philippe, and the LED is distal.
Okay, so we did
but of course, you have many tips and tricks to solve this issue. The best is to have a good nurse to take care of the of the wires. So now the pot was done with a 4.5 semi-compliant balloon at 16 atmosphere. So now we are supposed to have the stent fully apposed. Maybe you can do an angio, Philippe.
Yeah.
We have seen that we are really close to the carena, but not distal to the carena. So you see we have not done any damage to the circ.
So the lesion looks
so
exactly the same, yeah, as before the stenting, which is really good.
Yeah. So this is the beauty of this technique, is that you select the stent according to the reference of the LAD, then you do the pot, and you do not make carena shifting, which will be a big problem in this case because the circ is very big. So now, Philippe, we use a third wire to go into the circ, and then we will open the strut toward the circ with a non-compliant balloon.
Yes, I think it's important to stress that we can use a third wire to have a free access to the circumflex. It's a real big vessel, and I think it's safer to use a new wire and try to cross the distal cell, as I did now, rather than taking the water of LAD. Tu m'as mis un truc.
So Thierry, as you said, it's a dominant circ, so it makes sense to do something for the ostium, but indeed, here in 90 years old, one could consider just to say the circ is TME3, but I agree that it's a very dominant vessel, so it's
large. But
yes. So you see, it was relatively easy to wire through the stent strut, but then crossing the lesion is not so simple.
It's done.
Yeah.
It's a workhorse wire, Thierry? Yeah, you just take a regular wire.
Run-through.
Run-through.
Yeah, it's a run-through.
Wire.
All the wires are run-through. I think you can go also in the other branch, Philippe.
Is that one? Okay.
Yeah. Okay. So now the next step is very important. So removing the gel wire may attract the guiding catheter.
Yeah.
So you may damage the proximal part of the stent. So make longitudinal compression. Yes. So this is what we call the left hand control. So Philippe will, with the left hand, will control the guiding catheter in order not to have the guiding touching the stent, and at the same time we will pull back the gel wire. Again, the nurse is very important to because she knows which wire is which one.
So disengaging the guiding catheter now is very important and not very risky because it's still on 3 wires, of which one is jailed. Yeah? So you don't risk much, and we know that stent deformation at the ostium of left main translates into clinical outcomes. Yeah? So this is really important.
Absolutely.
Yeah.
And Thierry, would you consider?
Yeah, Maciej,
sorry, please, Thierry.
Yeah, Maciej. No, it's okay. Maciej, I fully agree with that. I think it's a very important point to remind that in Excel, if you have a longitudinal compression, the MACE rate is doubled at 3 years follow-up.
That was one of the independent predictor of MACE. Yeah.
Absolutely.
And Thierry, could you consider also to leave the jail wire to advance the non-compliant balloon in the ostium of the circ and to use it as buddy wire and then to remove it just after you place the balloon? Which can give you more support in case it's challenging to cross?
Yeah, I think it can be useful, but you may have difficulty with the 3 wires. So I prefer to use the non-covering balloon in the LAD in order to have more support to cross the stent strut of the circ, if needed. We'll see.
Thierry, you used a semi-compliant balloon for the proximal optimization, right?
Yeah.
What was the rationale behind that it's semi-compliant and not non-compliant?
Because we can play with compliance of the balloon, so it's
very easily.
I think Philippe has done a very good job because it means that he went through the distal strut and was able to cross very nicely. It's also because the pot
was
done
correctly
also
performed.
Absolutely.
Yeah, I think it's a very good point.
See that
here with the pot you've treating the malapposition and not anymore to dilating a resistant lesion. So actually you took benefit of the semi-compliance.
Philippe, peut-être on va avancer.
Especially because here there was Medina 011.
Yeah.
This means that there was no huge plaque over there to deal with.
Right. So we make an angio just to check. Yeah.
Okay, vas-y.
So I think you see we have some dissection at the ostium of the circ. And because the lesion is really long, longer than 10, I think it's better to stent in this case.
So what size of the balloon is now?
So this one is
at 3.5.
3.5,
Okay.
8.
And Thierry, Philippe, would you consider to optimize the distal part of the stent left main LAD before fixing the left main and the neocarina if you do a tap?
No, I think we have time to do that. The distal optimization will be done with the 3.0 balloon. So Philippe, which kind of stent maybe?
So the balloon was at 3.5, and you see that the vessel is really huge.
Yeah.
Bigger than that.
Yeah. So we can.
So I think there is the balloon. This is a 3.5. I would say 3.5 or 4, and length could be 15, something like that. 15.
3.5, 15. Yeah. Okay.
Thierry, just a question, because you might have difficulties to deliver this large stent through this angulation and calcification. Would you consider to put your wire more distal to have a bit better support?
Yeah, of course. So maybe we can post-dilate at the level of the...
And another suggestion is using a smaller diameter of a stent. Given the post-dilatation capacity of Ultimaster, you can always post-dilate 2.5 stent
of course.
up to more than 4. Yeah, so you're still in a good. Sometimes just choosing the smaller stent mounted on smaller balloon improves the deliverability of the device. Yeah. Here you have a calcium, you have angle, and you can always post-dilate 2.5 up to 4.
Yeah.
Excellent suggestion we will keep in mind, but for this we try to go with a 3.5, and if we're not going, the most important is not to force, of course. Take second option, as you said.
And Philippe, Thierry, if you plan to do T or tap, it's always difficult to know exactly at the end, but will you place parallel balloon in the LAD while you deploy your stent in the circ? Yeah.
Absolutely.
Yes, of course, it's this very important point. There is many advantages of doing that. Is that you will be sure that you will be able to put a balloon in the LAD because you have already the balloon in place. And also it can be very useful if you are not sure about the optimal positioning of the stent. So you can inflate, you can position your stent where you think it's good, and then you will be able to inflate the balloon and check that the balloon is really in contact with the stent. So now because we have not this view looks not bad, Philippe, I think.
Yeah.
So what we can do is to do a stent boost live.
This is what we do now.
And okay.
Position.
It. Okay.
Stent.
So
What
there
do
is
you
some
think?
inertia. So maybe do it again.
Yeah. There is some protrusion, but not so much.
It looks perfect now. It's a partial protrusion. Yeah.
It looks ideal. You
Francesco.
just have to put the balloon in the LAD and...
Yes.
Yeah.
It is also interesting to remark the fact that the markers of the balloon are in this particular stent outside the stent straps. So
short gap.
and
absolutely.
If you do not perform this good magnification, good incidence, you may end over with a too long carina due to the fact that you rely on the marker instead of the stent struts.
Or you can miss the ostium sometimes.
Yes, or on the other side. Yes.
Yeah, this is the beauty of stent boost. I think this technique is really underused. It's very important for positioning stent bore a bore, for example, for doing a T, for checking that you have full expansion of the stent everywhere. So this is very useful. We use it nearly in all cases.
Especially in cases where you really want to spare contrast.
Exactly.
Yeah.
Absolutely.
Yeah, it's cheap, contrast-free, so it's true that it's.
I can even elaborate more on this. I think that if you are using IVUS guidance, I mean, you may use the catheter several times, and you may answer with the IVUS probe to many questions that may also be assessed by the stent magnification. So if, like in this case, you embrace the OCT, the number of pullbacks has an impact because you administer contrast. So to have this multi-modality approach makes sense because many aspects, namely, I mean, the expansion, the position of the stent, may be checked very well by stent enhancement.
Yeah.
So we are doing stent enhancement, stent boost live again, because as you've seen, we've been going in the LAD with the balloon for the kissing, and just to check that.
Maybe it's a little bit more proximal.
It's a little bit inside, yes. I agree. So maybe I will push
So Thierry,
with the stent boost.
So you park the balloon in the LAD distally from the left main, and after you pull on the balloon, huh? Correct?
Yes.
Yeah.
But given the fact that there is almost a right angle, and if you recross through the distal struts, the neocarina will be very short anyway, even if you protrude a little bit more. So I would allow it even for a little bit more protruding of this stent, because with almost a right angle, the neocarina, I don't know, Francesco, whether you agree, but the more narrow the angle, the longer the carina. Here, the angle is almost, the 90 degrees. Yeah.
So here, Thierry, you aim to very limited protrusion, no? It's really T more than tap.
Quite a T. Yeah, absolutely. Because it's T-shaped, so you don't need to have protrusion or very little if you are not sure. So now we can do the kiss, not too much protruding in the polygon of confluence. So maybe push a little bit the LAD, Philippe, just to avoid the...
And the 7th French was a good option at the beginning, huh?
Absolutely, that's why we selected 7th French to do that.
Okay, so now we do the kiss. So it's very important not to do the kiss when you deploy the stent, but wait for deflation, good positioning of the two balloons, and then do the kiss. And now the other point, very important, is not to touch the neocarina, even if it's very short. But in this case, I think there is nearly no neocarina.
Yeah.
Again, Philippe, it's an important time for
so now what
to be
we have
safe
to
for
do
the
is to
stent.
optimize the LAD stent, Philippe, with a 3O balloon.
Absolutely. I just take care of the stent in the left main because we have two big balloons, and when you are going out, you may engage the guiding catheter. So it's another important time to take care of.
So you can see that the stent is not damaged. There is no longitudinal compression. We see very well the stent in this view. Now Philippe will do optimization of the
distal part with the 3-0 balloon.
Stent. So dot technique. So we can use again the stent boosts to check. You see, you are at the level of the poor expansion of the stent, I think.
Yes, I should be there.
Looks good, huh? Can do several inflation.
Not so easy. Okay, you can go there.
Okay, so it's better. How much?
You're 12, 14? Yeah.
14 now.
So this is non-compliant.
But there is quite a sharp angle here on the...
Yes,
absolutely.
It's not only lesion and calcium, it's also angle.
So I think...
okay, now it's going very easily. So we change a little bit the position, so Philippe, and we can do another one.
Can do again stent boost if you...
Yes, we go to 14 because I change a little bit the position, and then we do some stent boost, and we'll be ready for imaging.
Perfect.
Okay, off.
Okay, so now the next step is to do OFDI. So we'll check that the result is good in the LED. We have full apposition and expansion. And we check also that the left main in the stent in the left main is okay. It looks good, huh? You see the calcification very nicely.
Yeah, in the inner curve of the stent.
A small waste in the distal part of the stent, but I think it's not very important.
Yeah.
Okay.
As long as lumen is good, I would not, increase the diameter of a balloon. We are risking perforation, which maybe
Absolutely.
Yes, definitely.
Fully agree with you, Maciej.
So we will go for OFDI?
Yeah, very good. So you know that we have Yoshinobu, really an expert in OFDI, but not only OFDI, Yoshi. Every year he's coming to Maciej, so it's really a pleasure to have him on board. And we'll see what you think about the result.
Il va arracher le bras.
And here, the idea, of course, is to do just one run, as we already discussed, because of renal dysfunction.
Yeah.
Yes.
So you will just assess left main LED, correct, but in patient with absolutely normal renal function, we might discuss to do both branches in left main bifurcation with two stents.
Of course. Yeah, of course. So what is very important with the left main, because I know that many people don't like to use OFDI or CT for the left main. What is very important is to have the correct output to have good images. So in this case, we have a left main which is 4.5 or 5 millimeters. So it's very important to use more than the size of the left main. So in this case, we start with 50 milliliters per second. And I think it will be...
Perhaps you pull the on guiding catheter, yeah, because there's a... Yeah,
good.
Thank you for the suggestion. Yes, there was some conflict, and I was pulling the guiding catheter while pushing slowly the probe. We try to go a little bit distal.
No. We need to have the FDI on the screen.
It's not working.
Yeah. It's difficult here, Philippe, to advance on the bend that we identified earlier.
I should push, I'm not sure, because the plan was to check the left main and distal left main bifurcation.
So maybe we'll do it here. We'll miss the distal part, but
there is difficult bend.
Are we close to the left main, Philippe?
You definitely landed with your stand in a relatively healthy area, so I do not expect. I would not expect any edge dissection there. So the important is.
So Yoshi, you're ready?
Left main bifurcation and proximal LED.
Oh, are you thinking it's kink?
Yeah, perhaps there's an issue with catheter.
Ok, on n'a pas d'image en fait de l'OFDI.
So Thierry, waiting for fixing the software or maybe the probe. We had also question whether we need to do report after the kissing of the tap. We'll discuss that after.
Yeah, it's a good point. The plan was to decide if we do report after the OFDI analysis. Okay, is it okay? Yeah. If we do the kissing just only in the polygonal confluence, you do not make deformation of the stent in the proximal part of the stent. But maybe we should finish with a pot in this case. And the strategy was to check by OFDI if we need to do it or not.
Mm-hmm.
OK. OK, donc tu fais signer, Philippe. Vas-y. Vas-y.
Oula.
OK.
So quick. Yeah. Okay.
I don't want to influence Yoshi.
No. Neither me.
But
So Philippe, yeah.
Bougez pas, monsieur.
So Yoshi, please tell us.
Yeah, he's making the analysis. To take your time. What we can do, Philippe, maybe is to do an angio in the aereo caudal view.
Yes, I think it would be informative for the circ as well.
While Yoshi is working on the images.
Thierry, we still have 2-3 minutes more to look at the OFDI before joining in the room to discuss, so it's fine.
Okay, so what do you think?
So I think the result is quite good. I think this is from the proximal LAD. You can see that the stent is well expanded. So the size is 3.1, 3.2. This is the left main bifurcation. You can see that there was a really minimum protrusion of the struts, and wire is coming from the circumflex. Left main is quite nice. There was a small malposition, but I think it is probably less than 300 microns. So I think, yeah, so I can make a measurement, but I think it is like this. So let me change. So overall, I think the result is quite good. Yeah, I think it's yeah, just take a distance. Yeah, it's a small malposition. I think even probably not the malposition because
because we see only the reflection of the. We don't see the thickness of the strut. Yeah, so we have to.
Exactly.
We should add
taking
the
into
80 microns more plus polymer.
Yeah. You're right. So I think there's no significant malposition in the proximal part. Stent is very well expanded. Maybe I can show the one 3D reconstruction to see that its ostium is the widely open. I think from the longitudinal view, it's a very much well expanded. So if we just do this 3D image, maybe I can show the ostium.
Okay, thank you very much, Yoshi. So what do you think, Thomas, Gabor, Francesco, Maciej?
I think both on the NGO and the OFDI, I think it's a beautiful result. There is no malposition, no edge dissection, no underexpansion. Maciej, Francesco, what do you think?
Yeah, I think the result is quite optimal. Yeah, so also angiographically is really good. What we wanted to know is the minimal luminal diameter of the LAD, and I understand that it's okay. And also for the left main, the apposition is good. So I would leave it like that.
Yeah, and you see in this carpet view that we have a nice
open circ.
Opening of of the strut toward the circ. So I think it's very nice.
The circ looks really beautiful, and the whole bifurcation looks beautiful.
Yeah.
So,
No, I think it's really beautiful, and Thierry, Philippe, all the team, really congratulations for this beautiful and challenging case. As you've seen, we have so many questions to you just after when you will join in the room. But again, congratulations to you and all the team.
Okay, so we are coming to the time to react.
So while Thierry and Philippe will join us in a separate room, and then the team can take care of the patient, obviously. Just to remind you that you have mics in the room, so really feel free. It's nice that you send the chat to Hakim. We really enjoy it a lot. But also we are in the same room, which was not the case during the 2 years of COVID. So it's good to send SMS, but it's nice also to talk directly from mics being in the same room. So we had a lot of questions. Maybe the first one for Maciej, and as soon as Thierry will join, we will discuss that with him. It's about the calcium modification in this case. Do you think, according to the after stent result and also the degree of calcification, you will go upfront with the dedicated device in this case?
Yeah, not with this result. Yeah, of course. Perhaps if the patient were not that old and no issue with renal failure, then I would check before. With OCT or can also use IVUS, and if there were massive calcium, like calcified ring or 270 degrees calcification, then of course I would start with some ablative technique, perhaps ROTA, perhaps IVL. But with this result, they checked with NC balloon. The balloon expanded with 12 atmospheres. Yeah. I think that was, keep in mind that was very complex and fragile, very old patient. So we have to stay as simple as possible.
But it's true that in spite of full inflation of the balloon, we still have some stent under expansion. So it's, and you say it according to the result, but the problem is when you have to decide at the beginning, you don't have the result yet. So it's.
Yeah, of course.
We had the question from the colleagues in the room whether this is not right away an indication for scoring balloon, which is an intermediate solution for calcified. You are not rotablating, but you give another chance to direct the plaque modification.
Yeah, lesion preparation, of course, is important. Yeah, because it may hamper stent delivery, stent expansion, but what they did, they just used NC balloon. It opened fully. So I think that was quite reasonable to go with stenting then. Yeah.
So, do we have Thierry and Philippe who already joined to discuss or not? Not yet. Okay. Gabor, I'm sure we have many questions from the room.
Yeah, we had a question. How do you see the pros and cons IVUS versus OFDI for a left main? And as well, whether you have a specific technique to optimize your OFDI quality in the setting of left main.
So I think that IVUS should be regarded as the gold standard for evaluation of unprotected left main. There are emerging data also in this PCR. There was the Rolex study that was in late-breaking trial session showing that there is a clinical advantage with the use. But still it is underused. So I think that you may use OCT if you are confident to get this kind of images. Yeah. And the problem with OCT, I mean, let's skip the concept of contrast, is the fact that you need a learning curve specifically for unprotected left main to have these very good images without administering too much contrast. If I can summarize, it is very important that we do not perform the full injection and then we find that the guiding catheter was disengaged. So it makes sense that you take care about your time in aligning perfectly and then you just perform a little test and then you perform the image. So these are the tricks.
Yeah, but the truth is that 80% of left main lesion is bifurcation lesion. Yeah, so then also OCT works, and we have also the Lemon study, the first pilot study showing that OCT can be also used for guiding this kind of procedures. And if you go to PCI online, you'll find a nice paper on the use of guide extension catheter to use it for ostial left main. So you can use guide extension and also visualize with OCT. Not every guide extension, but just go to PCI online and you'll find this technique. So with using guide extension, you can visualize also the ostium of left main with OCT.
It's true that some OFDI are OCT compatible. That's that's a big plus.
I think one more thing that we can discuss before the team from Maciej joins us. There were questions, and we already touched on point briefly, but what is specific in proximal optimization after TAP, after T and TAP? Why it can be justified that it was not done now, or if you do it, what is the specific aspect that you have to really take care of? Francesco?
So I think that we should remember why we are performing re-POT in our interventions. We are doing it to restore the round shape of the left main when we think that we induce that distortion. So re-POT is something that is inside our routine practice, but we should not take this as a rule that should be done every time. In this particular case, the technique was T-tap. I think that the operators took the correct timing to have perfect position, so protrusion was very limited. It was perfectly done. However, anytime there is some neocarina or the depth of neocarina, it is really not advisable to jeopardize the final position of this neocarina attempting to perform a POT. So what Thierry said was, I mean, we will get the advantage of imaging to understand if we did perfectly POT at the first time and we induced a distortion. Yeah. They didn't perform POT. I think it was perfect.
So Thierry, Philippe, as you heard, Francesco said that you did everything nicely. So again, congratulations. But of course, we had many questions from the audience, and one question which came many times. They said that the disease of the side branch is clearly significant. It's long. It's an important side branch. So why not going upfront with the two-stent technique? And many of the colleagues suggest the decay crush. So I would like to hear you on that, Thierry, please, or Philippe, of course.
Yeah, we never do decay crush in Maciej, so it's simple. We do decay crush just in case of bench work. So our strategy is it's always provisional. Sometimes we end with two stents, sometimes we don't. For left main, I would say that in about 15% of cases we use two stents. For other bifurcation lesion, it's less than 10%. And the problem with decay crush is that you always use two stents. Of course, I think it can be a good option when you have a lesion like we had, which is a lesion with two long lesions, LAD and circ. So people who are fan of decay crush, I think they can do it, providing that they are following all the steps, which are 12 steps, which is very complex, in fact. But if you follow all the steps, you may have a good result at the end, knowing that you will have 3 layers of stent at one part of the left main. I don't know if
on top of what you said, Thierry, I mean, in the perspective of this HBR patient, and we want to have the DAPT shorter as we can. He's a 90-year-old patient, so I think it's really important to have less device, less layers of device in the left main, especially. So it's for me, the most important reason why, for this patient, the simple was the better.
So you mean it's routine practice, as I knew Thierry in Maciej, of course, but even more probably in 90-year-old HBR patient, you don't want to have 3 layers of metal in the left main. Gabor?
Yeah, it's a very important question from the audience. They mentioned that normally we size the stent according to distal vessel reference diameter, and they mentioned that in this case the 3.5 might have been a bit oversized for the LAD. Why didn't you choose the 3.0? So please, because it's a very important stent selection aspect for the left main, so please elaborate on this aspect.
Yes. Yeah, I think it's a very important point. So when we are treating left main, we quite never use a 3.0, because we know that at the end, if you go up to 4.5, it's like using a 2.25 that you push up to 4.5. So we know that the the scaffolding of the left main will be very poor in the left main if you use a 3.0 stent. So that's why we deploy the stent at very low pressure. You have seen that we leave some residual lesion. So we deploy at 7 and then 8 atmosphere this stent in order to have a position of the stent, knowing that at the end we will use a 3.0 to optimize. And that's all. So, but at the end, we have a 3.5 that we can push up to 5 or 5.5 if needed.
So the key is the stent expansion limit. Yeah, 3.5 stent has very big, larger expansion limits that you can go up to 5 or 5.5.
But that's a nice take-up here, because for years. No, please.
If we deploy the stent at 3.5 at 14, then we take a big risk of pushing the carina, closing the circ, etc. So I think it's a big compromise, but it's very important to follow this advice in order to have a very good scaffolding of the stent in the left main.
Yes, and we can do that because it's a very, very good stent for that, to a two-link structure which is very nicely expandable. So have you seen we've been with a 4.5 up to 16 or 18 atmospheres, and the result with OFDI was really nice, with a good position on the left main.
It's nice here. It's a good teaching point because we learned for decades that we have to size always the stent to the distal vessel, but also we have to look at the proximal part and how much we will need to do over expansion and to find a compromise. So it's
absolutely.
So also, of course, Thierry, we had and Philippe, we had question about the optimal strategy because we have a HBR patient because age, renal dysfunction, prior TA, but also you end up with a quite complex left main bifurcation stenting with 2 stents. So what again will be the compromise, because it's always about compromise in this case, about the DAPT strategy?
Well, I think, of course, we have a bifurcation with 2 stents, but I think the duration of the APT should be taking account all what you said. It's a 90-year-old patient. He's really good. He's going well. He's very active. So I think we have to go for 1 month, maybe 2 months, no more. The APT. I think 1 month could be a good compromise. The fact that this is a left main is not really in itself a limitation for short DAPT, because left main is a big vessel, so we don't have so much risk as compared to small vessels or distal bifurcation lesions. And I think because we had an easy technique with 2 stents in a T shape, we can go to 1 month DAPT and then single antiplatelet for a long time.
Yeah, and the fact that we have done OFDI at the end is also a very important point, because of course, if we are not happy with the final result with OFDI, maybe we will prolong the duration of DAPT for 3 months or 4 months, I don't know.
So you mean imaging is reassuring to stop DAPT early in this kind of
absolutely.
patient?
And one more really relevant question from our colleagues in the room. Do you test routinely platelet reactivity in such patients when you go for short DAPT?
It's a very good question. So we have done that for many years. And at that time, we are not doing it. So we stopped using this DAPT evaluation maybe 4 years ago, something like that.
Yeah, 4 or 5,
because we had the conviction that it was very important, but at the end, we were able to identify the patient were hypersensible to DAPT, so patients who are bleeding. But of course, clinically, you can make the diagnosis because the patient have hematomas, bleeding, so you can reduce the dose of aspirin and sometimes the dose of clopidogrel. So today we are not doing it.
Yeah, agree.
No, but there is still some resistance to clopidogrel and high on platelet resistance. So we have to take that into account, especially for this kind of PCI, because if we leave the patient with clopidogrel alone and he is resistant, so he has no antiplatelet agent. But no, in routine, we don't do that anymore.
Okay. Great, again, Thierry and Philippe. So we discussed the left main strategy, the DAPT, but as you say, both, I think the imaging really had a lot in this case, because especially when you have to stop 1 month after. So we'd like to hear from Yoshi. What do you think OFDI can really bring to in the setting of complex PCI? Yoshi, can you?
Yeah, thank you, Thomas. First of all, I think pre-procedure OFDI, if available, it is useful to identify and understand bifurcation lesion, which is sometimes difficult from the angiography only. Secondly, you can also assess the plaque distribution, for example, calcification or depth of calcification, or maybe the lipidic plaque. And also the sizing for the stent is important. Can you go next? Go next. So this is the sizing for the stent. Of course, there's a natural tapering after the left main bifurcation. And like today's case, sometimes you need to create the discrepancy between the proximal and distal stent. And I think OFDI or the OCT measurement will really help the operators to do this precise sizing. Go next. During the procedure, go next slide, please. Yeah, you can also understand the interaction between the stent strut and bifurcation. One of the major points is the recrossing wire position, so that it's better to take the distal cell in general, so that you don't create a metallic carina. Go next one. Also, the another things to avoid is external wiring, of course. Go next slide. Yeah, so this is a optimal recrossing point, depends on the stent design as well as the configuration. Go next. Yeah, this is an example of the external wiring. So I think by using the imaging, you can really avoid those things. Go next. So finally, I think, like in this case, we make sure that the expansion is fine, and we also see that there's no major malapposition, no dissection, no major prolapse. So to make it safe to stop the DAPT early, or the abbreviated DAPT, the imaging is very important. And I did just a measurement on the LAD ostium and the proximal left main. LAD was more than 6 square millimeters, and the left main was very huge, 16 square millimeters. So today's case was really the good example of the stent expansion. Thank you for attention.
Thank you, Yoshi. Very clear take-home for the use of specific OFDI in complex PCI. Maybe one question from Maciej. Here we've seen a left main, but among the complex PCI in your practice, we know we cannot do imaging for all cases, unfortunately, but it's still the situation today. What are, in your practice, the best indication for imaging to optimize complex PCI?
Yeah, any complex disease, because any complex bifurcation, when I assume that I will be using more than one stent, because then I know that the disease is really diffuse. It's just not just a pinch at the ostium of a side branch, because then it's mostly it's just a large plaque burden in the main vessel. But whenever you want to deploy two stents, then of course it's nice to do imaging. And we are lucky in Poland because we have not only I was reimbursed but since April we have also OCT reimbursement. Yeah? So now we will be able to use it more and more frequently. Yeah?
Francesco, focusing on the bifurcation, what is your rate of imaging, meaning in bifurcation, and what is your?
So honestly, we use quite a lot, and we are also we enrolled in the October trial that will add a piece of knowledge in the field. That is a prospective randomized trial that is compared OCT or angio guidance in complex bifurcations, and unprotected left main was included. So the problem is that in Italy we have no reimbursement for both IVUS and OCT. So we do not routinely use, but I want to elaborate a little bit more regarding the possible use. If we start without imaging, it also does not imply that we cannot end up with imaging in the case we have any doubt. So here the operators decided to apply OCT just at the very last stage to, to check for the doubt interruption and the optimal result achievement, but also I think that in complex procedures sometimes there is something that goes wrong, and we do not rely really on what is the problem, if there is some under expansion, if there is some thrombus, and to react just based on angiography. If we have the imaging in our lab, it is probably not advisable.
So maybe it's also one of the responsibility of the community, because if we truly believe that imaging improves the result of PCI, probably in the coming years we have to fight to get reimbursement as we had for many other physiology device or other, because if we think it's improved patient outcome, there is no reason not to get reimbursement soon. Maybe, Gabor, a very practical question. So we've seen in this case that Thierry, Philippe, Yoshi and the team decide for renal function just to do it at the end, which really makes sense. But usually we try to do it before and after. But do you see any other time point during the bifurcation treatment where imaging can be useful?
So I think for me, there are three critical questions I want to get answered, either from the NGO or when I'm not 100% sure, then from imaging, and I would say that it's strongly recommended to keep this threshold low enough not to believe that angiography gives all the answers. What are the sizes, the diameters, especially in the left main? Then whether during rewiring I'm really in the lumen and didn't pick any stent strut, so no failed wiring. And finally, that you have good apposition at the end of the procedure overall, and good opening, good apposition. So I think these are the three key questions, but you need to be 100% sure about during any bifurcation PCI, especially left main.
Okay, great, Gabor. So I think I will come back to you again, Gabor, because in this case we've seen the imaging, which really had a lot, but also the stent selection. In this case, so we've seen left main, complex PCI in truly high bleeding risk patient. So Gabor, what is the rationale to you for the use of Ultimaster stent in this specific case?
I would suggest to go to the slides that we are prepared for this discussion, because actually it's an important thing. So Ultimaster drug-eluting stent is really has strong clinical data supporting its use in HBR patient with shortened double antiplatelet strategy. Yes, so I would like to first just to show you briefly the design of the trial. In the study, patients were recruited 1 month after PCI. So 1 month after PCI with the Ultimaster drug-eluting stent. And there they were randomized to abbreviated or non-abbreviated DAPT regime. In both groups, we had patients with no indication for oral anticoagulation. In this case, in the abbreviated group, the DAPT was stopped and single antiplatelet therapy was continued. While in the non-abbreviated group, of course, double antiplatelet therapy went on till at least 6 months in total. While in the group with indication for oral anticoagulation, in the abbreviated group, the DAPT was stopped and single antiplatelet therapy was continued to in total 6 months after PCI, while anticoagulation went on. While in the non-abbreviated group, the DAPT was continued at least 2 more months, and then single antiplatelet therapy at least for 12 months in total, and then oral anticoagulants further. So in general, we compared in high bleeding risk population an abbreviated and a non-abbreviated regime. And of course, sounds logical that there is a benefit in terms of bleeding. You give less anticoagulants, less antiplatelet therapy, there will be less bleeding. What is more important that while you had advantage on the side of bleeding, there was no access in terms of ischemic risk in this patient treated with the Ultimaster stent.
Yeah, thank you, Gabor. Very clear, but as often what we do in the cath lab is based on evidence, of course, but also on experience. And beyond this scientific evidence, which is really key in the field of patients with high bleeding risk, do you have any argument regarding the mechanical characteristic of the stent also supporting the use of Ultimaster in this case?
Yeah, when we talk about left main and left main PCI, left main stent, we have to understand left main is a bit different animal than other locations. And here in the left main setting, the stents are really exposed to extreme conditions, and they have to fulfill extreme requirements. First of all, the expansion capacity is really important because you have a remarkable mismatch between the distal daughter branches and the left main. Second, the cell opening capacity has to be large enough to go in a huge side branch. Like in the case from Thierry and Philippe, it was a huge side branch. You have to be sure that your side cell of the first stent can be opened up large enough for this for the circumflex in this case. Second, the radial force. We are treating calcified patients, so the radial force is crucial. And what we just discussed a couple of times during this case, the longitudinal strength is also a key aspect. Why? Because you are just pushing on the entrance of the stent with balloon, with the guide. So if there is no sufficient longitudinal strength, you can just mess up your case right away at the beginning.
Yeah, thank you, Gabor. So it's nice to see that the decision we are taking in the cath lab are based both, of course, on evidence, which is key, but also on the specific characteristic of the Ultimaster stent. Maciej, maybe since the result of Master DEPT, did you change your practice regarding the management of high bleeding risk patient? Meaning, do you feel safe to stop very early DEPT?
Yeah, of course. Why shouldn't I? With this study, so many patients randomized and all over the world, almost so, and really good results. This is really a reassuring study for me to stop DAPT shortly. I mean, after 1 month. The first thing is to do the correct procedure, as we just have seen with imaging, and be sure that your procedure was not spoiled. Because if you spoil the procedure, if you expand any stent or malapose largely, then you may have issues with thrombosis. And then, of course, this stent has really the best data until now for shortening DAPT in patients, high bleeding risk patients. And this is quite a big number of patients. Up to 40% in our cath lab is 75 years or older, or needs to use oral anticoagulation. So this is quite a big number of patients. And now, of course, we adapt the study, and in cases when we use Ultimaster stent, we really tend to shorten the DAPT. And of course, when we have a patient with a high bleeding risk, this is our first choice, to choose the stent, because we have such a good data now.
Yeah. Before asking Francesco, I have a question difficult for you, Gabor. We have always the same question. So it's specific study with one single stent, only Ultimaster. Do you think those results can be applied to other modern DS?
No, I think what is important that we have to understand that these data are collected with this device. This data supports this device. So I think this is very important to realize that it's just like with medications, that the design, the study design, the device what we use, it gives a support for this indication with this device in this population.
Okay. So it means we need specific data for other devices if we want to extrapolate. Francesco, so when we see Master DAPT suggesting that we can use 1 month, but still in high bleeding risk patient, do you use 1 month for all the patient, or sometimes, of course, you have still to balance?
So honestly not. I think that high bleeding definition is very wide, and I think that the individual risk of bleeding is strongly dependent on the combinations and not just a yes or no phenomenon. So this is, but the fact that we have data collected in this group of patients is something that should be really taken in mind during the decision. honestly, in our practice, we try to do decision patient by patient. It is not the same if you end up with a single stent, well expanded, checked by OCT, or a patient in which he presented with acute coronary syndrome, you had to implant a lot of drug-eluting stent, you had to complete in another lesion. So patient by patient decision, trying to tailor it, but putting this data in our flow.
Thank you, Francesco. So I think it's just time to try to find the key take-home from the session, and I think I have three in mind. The first one, when we treat HBR patient, especially elderly patient like this one with distal left main, we have to do everything to keep it simple, but also to optimize. And for that, I would like to go to the second point, which was really the added value of imaging, in this case, to check apposition, expansion, no edge dissection, and then we know, or we feel at least, that it will be safer to stop the APT very early. And the third point, of course, is to consider to select the good device in such a difficult situation based on both the patient and the anatomy. And of course, in this case, it was based on evidence, and again, as Gabor nicely demonstrated, also on the mechanical characteristic of the Ultimaster stent. So again, thanks a lot to Gabor, Maciej, Francesco, and Hakim to be here on stage. Thank you, all of you, for all the great questions you just shared with us during the session. Thank you to Thierry, and wish you a wonderful meeting and a nice stay in Paris. Bye.
Thank you.